Okay, so we're back, better than ever. Okay, so when we left, we were talking about iontophoresis and how its treatment is calculated. So again, it's not done like we normally would do. We don't talk about frequency, or we don't talk about pulse width. We don't talk about amplitude. Well, we talk about amplitude. We don't talk about frequency, pulse width, on-off time, ramp, any of those things. We document iontophoresis in milliamp minutes of dosage. So you'll talk about which drug or medication you're iontophoresing, and then how many milliamp minutes of that you've actually done. And so let's see here. Let's get a visual of this. So you can kind of see what it looks like. Okay. I don't think I'm going to go through something that long, but that probably will be the best one. I'll put that online. Yeah.
Clean skin in preparation for the electrode.
Okay, so here we go.
Clean skin in preparation for the electrode. Ensure that there is no metal in the area to be treated. Using a syringe, inject the appropriate amount of medication into the pad.
Now you want to spread it around. You don't want to just hold it in one spot. Spread it around so you get good coverage over the whole sponge part of the electrode. So this is a sponge, and I'll show you how you put medication on it in just a second.
Place the electrode with the medication over the target tissue, and make sure the electrode is in full contact with the skin. Apply the other electrode and prepare to connect the lead. Attach the appropriate polarity lead to the active electrode.
Okay, so if they're attaching a black electrode, what did we tell you all the black electrode represents? The black electrode represents the cathode. Very good. Cathodes, are they negative or positive?
Negative.
Negative, which means the drug underneath here has to be
Negative.
negative. Very good. So they're trying to use the same charges to repel the negative drug or the negative medication into the skin through those shunts, through those areas where we can get things through the skin easier, hair follicles, sweat glands. We're trying to push it through those areas using an electrical current. So the medication is negative as well as the electrode, so they will match, because like charges repel, opposites attract.
This is determined by the polarity of the medication. Turn the unit on and choose the appropriate parameters based on patient tolerance. The typical dosage is 40 milliamp minutes.
And so if you scroll to the right on this device, you'll see it when they scroll to the right. Let me see if I can get it back far enough. Yeah.
The typical dosage is 40 milliamp minutes.
So it'll come on at 40, but you can scroll to the right and go all the way up to 80. So you can go up to 80 milliamp minutes, but the typical dosage is going to be a 40 milliamp minute treatment. So that's telling the machine how much iontophoresis you want to perform. I want 40 milliamp minute dosage, what I'm doing, which is pretty standard. Then you will set your amplitude of your current, and depending on the amplitude of your current, that's going to determine your actual treatment time. Does that make sense? Like, so if the patient that they're using can only tolerate 2 milliamps of current, what should take only 10 should only take 10 minutes is going to take double that amount of time, because they can only tolerate half of the actual dosage current that we normally would believe. So actual treatment time versus prescribed treatment time is usually different using iontophoresis. Okay, now turn to right, and that's setting the amplitude. And it goes all the way up to 4. So now they're 1 milliamp, 2 milliamps. Now they hit start. So because it's
Check in regularly with patients.
because they have 2 milliamps of current and they're doing a 40 milliamp minute dose, the patient is going to require 20 minutes of total time to have this done. Does that make sense? So if they went all the way up to 4 milliamps of current, then the patient would only need 10 minutes to get this done. But the actual time the patient is there is going to be based on how many milliamps of current they can tolerate. And again, DC is really uncomfortable if it gets really high. So it starts to bite, it starts to become really uncomfortable. So a lot of patients really would prefer lower current milliamps than the larger ones.
And assess the condition of the skin. When the treatment session is complete, turn off the unit, gently remove the electrodes, check the condition of the skin, and assess the patient's symptoms.
Okay, so that's how you would set up iontophoresis. Let's see if there's another good one. This one is one. I don't want to waste a whole 10 minutes on this one, but I guarantee you it's going to be good just because I know the person. The ortho-eval pal guy, I like his stuff, but we don't have 10 minutes to waste. So we're going to probably skip through. I'll put this video on
When the world
Canvas.
gave them setbacks,
Yeah, I'll put this on Canvas.
science
You can watch it at your
gave
own
them
leisure.
bounce backs. And when your vet don't
But we will.
Yeah, they get covered by.
So we're not doing the intro. We talked about what ionto is already. We kind of talked through the methods. So he doesn't even do the darn treatment. Okay, so I'll leave this for you to kind of watch.
Hello everyone, this is
Actually
Paul
do
from
a treatment.
Ortho-Eval Palette. Today I want to talk a little bit about ionto.
Yeah, I thought he was going to actually do the treatment. He's not even doing the treatment. So no. Trying to find somebody who's actually doing the treatment. Oh, so that you can see it. Okay. I do like these guys too, Bob and Brad.
This is we define without actually doing it. But this is gonna go right over that tender area. Now,
It's a little slow. We'll see what this guy's doing.
All right, so here today we're talking about iontophoresis, and basically what iontophoresis is to help reduce inflammation and pain. Also, it helps with some major diagnoses that we see here in biomechanical therapy, such as fasciitis, bursitis, tendonitis. It also helps with osteoarthritis and rheumatoid arthritis to help decrease the pain and inflammation in the joint. So we have two methods of iontophoresis that we use here at Biomechanic. One is by using this device here, and when we use this device, it takes about 20 minutes. And basically, people see information and effects within about a few hours. They normally have relief for about 3 to 4 days. And then also with a to-go patch that we also use, it takes a little bit longer to disperse the drug into the skin. That takes about 4 to 8 hours. And so now I'm going to demonstrate on how we use this method. Things that we see a lot is Achilles tendonitis. So basically we would take the disperse pad, put the medicine on the pad, and apply the Dex right at the focal point of the Achilles tendonitis. The other pad would go about a foot away as a ground. The negative side goes on the dispersed pad. Positive side goes on the ground. We set the dose, set the current, and then it's set, and it's good for about 20 minutes. The other one that we use is the to-go patch. So the same thing applies. The negative side goes to the focal point, positive side away, and the patient will leave with it on.
Okay, so that gives some clarity, just kind of showing you how it's set up. Okay. Okay, so the main thing is, how is the dosage report, how is treatment reported? How is it prescribed? Milliamp minutes. So that's how we're going to do it, milliamp minutes. And it's based on, like I said, the PT will normally give you some kind of clarity. They may say, I want 40 milliamp minutes. If they don't give you clarity, then 40 is a usual standard for treatment. It's where we kind of want to start and then build off of 40. So rarely do we usually want to stick with 40 and then go from there for your milliamp minutes. Okay, and again, it's really based that, so that's your prescriptive, but your actual time in clinic is based off the milliamps of current your patient can tolerate. So if they can only tolerate 1 milliamp, then they're going to be there for 40 minutes. If they can tolerate 2 milliamps, they'll be there for 20 minutes. If they can tolerate 4 milliamps, they'll be there for 10 minutes. If they can tolerate 3, they'll be there for 15. A little over 15 minutes, 15 and some change. So whatever. So it's based on what the patient can tolerate. You set the milliamps. The current starts to increase from 0 slowly, and then once it hits that peak, it's going to stay there. And you're talking to your patient the entire time. Hey, how does this feel? Is this uncomfortable? Is it really bad? If they're saying it's really bad, turn it down. If they say it's fine, leave it where it is. So the patient will determine the truth of what they're going to feel. Okay? Alrighty. Next part we'll talk about are the things that we use, or the things that we actually iontophoresis. So what do we iontophoresis? These are the drugs or the medications that we use for iontophoresis. I don't think they're in your book, so I think these are probably just a slide. So these aren't found in your book. So we're not going crazy with these. The major ones, all of these are good to know. Some of these we don't do, but it always is good. Acetic acid, so that's like vinegar. Acetic acid, some type of vinegar, dealing with calcific deposits. Again, you're looking for calcium-based deposits that have risen up either in the tissue or subdural or subdermal, and you're trying to break up some type of calcific deposit, acetic acid. Rarely do we do this one in clinic. I don't know very many people who do this or have done this. Calcium chloride, again, keloid scar tissues. Not a whole lot of people I know that do those either. It's just good to know. You may see this on the test. Copper. Never have I seen anyone iontophoresis copper in my life. It may be done for fungal. Dexamethasone phosphate, they really should say dexamethasone phosphate, is one of the main things you're going to see iontophoresis. Dex is going to get iontophoresis. If there's one drug on here that you'll see, Dex is going to be the one. It's that important. It's an anti-inflammatory, steroidal anti-inflammatory. So steroid anti-inflammatory, SAID drugs. So it's a steroid by nature, which means it has to be very closely monitored It's going to be behind some kind of locked door or cabinet. You're going to have to sign out the drug. You're going to have to document how much of it you use and that you put it back in the place where it was designated to be put back. Some clinics, they were making 2 people observe the process to make sure it was done right. So if you were doing it, they had another person there with you watching you put your medicines on there to make sure everything went well. So dexamethasone phosphate. Oh. So dex phosphate is one you're going to see clinically. So if it's one that you'll see, dex phosphate is the one. Iodine, haven't seen that one very many. Scars, adhesive capsulitis. Lidocaine is one that you may see clinically. A type of analgesia. I'm sorry. Analgesia. I heard you. I think you had already sprinted out when I came to get it. So yeah, lidocaine is one you'll see. So magnesium, kind of, sort of, you may see magnesium. Good for muscle spasm, muscle cramps. So you may see that one. Salicylates. That word is salicylates. And these are things that people use already as medications. They just probably don't iontophoresis them. A lot of the medicines that you get over the counter for muscle rubs and things like that, icy hot, you ever see icy hot, people talk about that. Biofreeze, a lot of that stuff, those are types of salicylates. They're skin irritants that either heat or cool once they are applied to the skin. So they're either a skin irritant that has a cool factor to it that makes the skin warm up, or either they have a warm factor that makes the skin cool down. But they're salicylates. Icy hot is methyl salicylate acid when you look at it. So all of those things are type of salicylates. Zinc is another one. You may see zinc if you're working in wound care. So keep your eye out for zinc. You may see that. So, and the major goal is to know the medication name. I'm primarily sticking to the major ones that I know that you may see clinically. Dexamethasone, know that one. Lidocaine, magnesium, salicylate, zinc are going to be the big ones that you'll see. Now, if you see the other ones, you can just like, hey, you lied. I saw some of the other ones. Great. If you do, that's incredible. Sometimes you will, sometimes you won't. So that's that information there about it. So those are the drugs that we would iontophoresis underneath the electrode. So the goal is you'll need to know why we're using it, and just as important, what's the polarity? Because the polarity tells you what polarity of your iontophoresis device you're going to need to use to actually do the effective thing you want done in the tissue. So without that, you're going to miss it. So it's very important that you have that clarity on that. So, any questions there? Anybody see ionto when you were doing clinicals? Or not clinicals, you hadn't been to clinical yet. Seen it while you were doing observations? Nobody? Really? Goodness and mercy. It really is not used anymore. You usually would see 1 or 2 people. So, adverse effect, again, there is a greater risk of skin irritation and redness when we're using this current. So because it has polarity, meaning it's a consistent current that has skin effects underneath it. Those flow of electrons will cause oxidative things going on underneath the skin. So you got to be careful with this. Don't get too high. Patients will report those type of symptoms: tingling, itching, redness. What people think is the drug is actually a negative effect of the actual DC current. So if they're saying, underneath the electrode, you should only feel, light tingling. It shouldn't be burning or biting or stabbing or pinching. If it's doing all of that, your amplitude is way too high. turn that thing down. You're gonna burn somebody. Okay? And this isn't a treatment I do on back-to-backs. So if I see a patient 2 days a week, I'm only iontophoresing one of those days. I give the skin a break. I don't want to overload the skin with this. So if I see them 3 times a week, I maybe will do it on a Monday and a Friday. But I'm not doing this back-to-back days, and I'm not doing this more than 2 days a week because of all of the effects. Okay? Always be careful to ask your patient, are they allergic to the drug? Not just the electrode, are you allergic to certain drugs and medications? You want to explain to them exactly what you're doing. So that's very much so important. Always explain to your patient what you are doing. I'm getting ready to use a medication. So on one end, on these, it'll just be medication under the electrode. On these, it'll be medication on one, and then we'll talk about the other. There's saline that goes on the other side. So it comes with these saline drips that you peel the top off and put it on the opposite side. So you want to talk to them about any medications or allergies that they may have, because that could be dangerous. Okay? So, always ask. So, last couple of parts here, getting into these application guidelines, page 300. Okay? Application guidelines. First thing it says, the clinician should determine the treatment area and the size of the drug delivery electrode. This is not meant for large areas. It's not meant for deep areas. It's not meant for things that are covered by a lot of adipose tissue. You want to do iontophoresis over something very superficial. You don't want anything with great depth. If it has great depth, find another methodology. So things I'm trying to do, like medial lateral epicondyles for epicondylitis, some stuff on the wrist, if I'm finding that. Biceps tendonitis, you'll get it right over there. So people do a lot of biceps tendonitis with it. I'm trying to think of other ones that I see or have done. A lot of upper extremity stuff. Heel cords, maybe over the heel cord itself. People like to do heel cords. You know, there's just not a whole lot. You know, it's got to be really superficial. So, you know, it's not something you want to do with a lot of adipose tissue or that's deep. You want it to be really superficial so it can get the job done. Because it's not getting that far into the tissue. It's not like it's going down 5-6 inches into the tissue. It's very superficial, 2-3 inches into the tissue. You know, so it needs to be superficial, whatever you do. So determine the treatment area is the bigger one. The electrode should be large enough to cover it, but not so small that current density is exceeded, meaning you want the electrodes to match the size that you're working on. Second, the clinician to saturate the delivery electrode with the drug solution. So that's going to depend on where you're working and how the drug gets there. So this is a simulation here of the drug. So your drug will come in something that looks like this. Okay, so it'll come in something that looks like this, like a drug medication bottle. This is just saline water, so don't worry. But it'll come in something like this. They will have needles that are there. So either they're needles that you'll screw in a point like this, or they'll come with needles that click onto the bottle. It really just depends. Either way, if you've never drawn medicine, the first thing you do, push all the air out. So that's the first thing. Then you want to inject your needle into your medication bottle, flip it. You're going to hold them both and then slowly draw out. And you're going to draw out based on what the electrode says. So on the back of every electrode, it tells you how many cc's or how many milliliters of fluid you're supposed to use to saturate this electrode. So this one here says 1.5 milliliters. So I have too much, but that's, yes, I have 2. But it should be 1.5 milliliters. And then all I want to do, if I'm working on this, is hold it over the electrode that corresponds with the polarity of the drug. So let's say this is dexamethasone phosphate. I'm going to hold this over the negative aspect or over the negative portion of my electrode, and I'm just going to soak the electrode. You're literally just pouring it out and soaking it. Make sure you get the whole thing as much as you can. Soak it as much as you can. After you're done there, make sure you replace your needle. Usually you'll throw that needle away, throw the end away, or replace it as whatever the policy is for the place you're working. And make sure the drug is returned back to the area where it was belonged so that there can be safety. Because again, these are steroids. These are drugs that can be dangerous if they get into the wrong hand. So you're going to draw out your medication, and then you're going to put that over the superficial area where you're looking to treat. Okay? All right, so saturate the delivery electrode, results in the surface electrode transferring the current with minimal density. Then number 3, clinician should determine the polarity of the drug. Make sure we understand that, and then place it where it should belong. Once charge of drug is determined, the appropriate electrode from the battery source should be attached, whether the cathode for ionic drugs and the anode for cationic drugs. And then finally, the drug delivery site and the return electrode should be thoroughly cleaned to remove the oils. Make sure that you apply the iontophoresis. In general, the minimal distance between the 2 electrodes should be about 2 centimeters or about 1 inch. So if you're keeping them on the same body part, you need at least about 1 inch space between the 2 electrodes. Then after that, you just turn it on. Okay. All right. Then the last couple of things we'll talk about is this hybresis or ibresis system. This part here is called the electrode. So this is the electrode here. This is the controller. Electrode, controller. The electrode is actually designed to be worn without the controller and still transcutaneously deliver medication to an area over a period of time. So it's called patch-only mode. So in case your controller isn't working or something's going on with your controller, you can do a patch-only mode where you just put the drug or the medication on the electrode like you normally would, stick it on the patient, and then you're going to tell them to wear it for 2 to 4 hours. And it's going to transcutaneously deliver through the electrode. It really can. If you want to treat, then what you want to do is turn on the device. It has on here a power button. You'll click on your power button. And then once you click on the power button, it goes into a standard hybresis mode or ibresis mode. What you want to do is click on the top. There's a button on the top called standard mode. So let me go back here. So there's a button right here on the top of it called standard mode. You click on standard mode, and that allows you to use this like a normal ionto unit, where you can select 2, 3, or 4 milliamps of current and treat for a normal treatment. Like if I want them to stay for the full 20 minutes, I put it on, 2 and have it run for 20 minutes for a 40 milliamp dosage. So that's called standard treat. So I just hit the button called standard mode, and it goes right to standard. It'll go to standard mode, and I can select either 2, 3, or 4 milliamps of current. If I have a shortened time period and I need them to get the treatment quicker, then I can do something called the iBreaces or hybresis mode. This is when you first turn the device on, it goes into that mode. It's a shortened treatment where the device will select 3 milliamps of current independently, and it'll run for about 8 to 10 minutes. After that 8 to 10 minutes, the controller shuts off, and then you just ask the patient to wear the electrode, and it's going to continue passive delivery for 1 to 2 hours. So you're opening the channels with that 10-minute treatment, and then it helps it to passively deliver for 1 to 2 hours. So you can do iBreaces, or in this case, hybresis mode. You can do a standard treat like a regular Ionto, or you can just do patch only. And there's a lot of brands now, they've dropped the controller and they just do patch only. So I think you can buy patch only electrodes off of Walmart, I saw the other day. So there's more and more opportunities to use this if this is something that you find that works for your patient. So, but again, you'll have a controller, and the controllers are powered by the base. So over there on the right, that glowing thing over there is the base. All you do is just slide the base down on the controller like you would anything else, and it charges just like a cell phone. Okay. And in the front, it has these nice little tabs, and they kind of walk you through exactly the things I just told you about. Standard treat, hybresis, it gives you all those scenario type things. Not scenario, it gives you all of those synopsis of the ways you can use this to treat, to enhance your patient comfort. Okay, so that is iontophoresis. The major thing is understanding that we use direct current. There is a charge that's built under the skin, so we want to be careful. We're using it to deliver medication to a superficial area in hopes that it's going to decrease pain by avoiding medication breakdown by the liver. We can do the treatments in 40 or 80 milliamp minute increments, and it's still going to be based on the tolerance of our patient to DC current amplitude. So that's what we're dealing with when we're dealing with iontophoresis. Any questions? And nobody saw this at all? And no observations? Good. Making me feel old as dirt. I feel like the old guy standing around.
Back in my day, we used to do iontophoresis. Bet you never did that, did you?
Not that old, I swear to you. People use this stuff. Okay, so that's a good place. Let your brains cool off. I'll give you about 10 minutes there, and then we'll come back and work through some more NIMS protocols. About 2 or 3 more NIMS protocols so we can start wrapping it up. All right.